How do premium lenses affect a patient's quality of life? This is Lorcan Butler. This is the iViews podcast from iNews. Thanks to Mainline Instruments, who support the production and distribution of this podcast and had no involvement in its development, finalisation, or the views expressed within. So today we're joined by Professor Dan Lindfield, and for our listeners who haven't heard of you, Dan, could you please explain where you're from and what you do?
Thanks, Lorcan. It's a pleasure to be here. So I'm Dan Lindfield. I'm from Guildford in the UK. I'm a consultant ophthalmologist in Guildford, head of school for Kent, Surrey and Sussex for NHS England, and a professor at City University in London.
And with regards to the amount of work you do, are you more cataract or more glaucoma, or is it 50-50?
50-50 really, and as hopefully we'll talk later, there's a huge amount of overlap there. They are almost like cataract and refractive surgeons are now seen as one. I think glaucoma and cataract are starting to amalgamate quite nicely.
And due to technological advances, there's been a huge change in the shift to kind of traditional lenses too as well, isn't there?
Yeah, I think we're lagging behind. So our refractive surgeon colleagues are all over technology lenses. So advanced technology lenses are commonplace in the refractive world, whereas glaucoma procedures was previously seen as monofocal only. And it was a very brave thing to do to venture beyond those lenses. And I think we've now had enough technology advancement that there's some nice middle ground options for patients. So we've got the classic monofocal lens, and we've got the previous sort of big divide to multifocal, trifocal, to diffractive technologies. And I think we'd all agree that they're not the best for patients with glaucoma. But the newer EDOF, so extended depth of focus, or enhanced monofocal, you may hear them called, but non-diffractive lenses with a bit of depth, maybe a diopter or two, a diopter and a half, seem to be really helpful for our patients.
When you say they're not ideal for glaucoma patients, is that due to just anatomical structure, or is it down to patient visual demands, or both?
I think it's the underlying glaucoma disease and how it affects our visual function. A lens that essentially splits light too much and robs too much light by diffraction can negatively impact patients with glaucoma, especially if they've got visual field defects centrally. So I think any patient with a central visual field defect, the central 5 or 10 degrees, we really shouldn't consider putting in premium lenses. But patients milder down the spectrum, so ocular hypertensions or patients with minimal glaucoma, then certainly the extended depth of focus, the EDOF non-diffractive category, are really quite attractive these days, and patients seem to do really well with them.
Obviously, you work in hospital and you work in private clinic too as well. Do you find there's a kind of a gap in the kind of, the availability of lenses that are available to you as a private surgeon in comparison to a consultant surgeon in the hospital?
Sadly so, and it's financially driven. The lens is more expensive, significantly more expensive, and even patients with private insurance, Bupa and AXA, for example, they do not cover premium lenses. They're all additional to an insurance policy, which is sad news. But there's a definite movement towards NHS trusts considering monofocal plus lenses, so rather than just a standard monofocal, and even they have a significant improvement to quality of life. We're getting 0.5, 0.75 diopters of extra intermediate vision. I wouldn't say it's near, but with some clever monovision tactics as well, patients can get some increased freedom from glasses. Nobody's promising spectacle freedom or spectacle independence completely, but patients don't suddenly need reading glasses for absolutely everything.
Yeah. And do you find people's visual needs are becoming more demanding in the private sector, that it can be difficult to pinpoint what the requirement is?
You've hit the nail on the head. This, matching the lens to the patient is a real challenge. It's a real art as well as a science. We've got a baffling array of lenses to help us now, which is useful, but also a challenge in itself. What we're also realizing is that higher technology lenses are much more susceptible to the stigmatism that's left behind. So the requirement for toric lenses is higher because the lens dictates that sill is wiped down as low as possible. And our calculators are moving away from just measuring, anterior corneal curvature and keratometry to posterior corneal changes as well. And actually, the calculators are becoming more and more precise.
Yeah. And does that put a bit more pressure on your chair time, having to explain the benefits and the advantage of each type and trying to match each one to a bespoke customer recommendation?
I think bespoke is a lovely word. It does take longer, and I quite enjoy that. It's nice to really get to know your patient before you make a choice, and I think we make a choice together. But it's only a few extra minutes, and that lens is in a patient's eye for the rest of their life. We're not taking away lenses and exchanging them, unless, in very rare faults maybe. But for 99.9% of patients, that lens is with them forevermore. So getting it right is really important.
Yeah.
You don't buy a car or a kitchen or even choose some shoes without trying things on first, but we expect a patient just to take an emmetropic monofocal. That's what you're having. And I think I'm really glad we've got options now.
Yeah, and probably the emmetropic population are probably the hardest ones to achieve success with, aren't they? I mean, you'll tend to find if you're kind of myopic or hyperopic and you're presbyopic, it's an easy one, but the emmetropic pre-presbope or kind of, early presbope can be a bit more demanding.
Yeah, exactly. And the low myopes are the ones that worry us most, because we all think emmetropia is a good outcome, but for a -2 myope, they quite enjoy their near vision. And actually, that's probably the hardest chair time is discussing what to do with a -2 myope.
So giving tips then to maybe people who are kind of, in their training, what tips could you kind of give them to try to find out what the best vision is the patient is expecting to have from this?
I think it's about data gathering. So you want some really good data. We tend to only measure best corrective visual acuity and a pinhole. Some NHS clinics don't even measure unaided vision with or without glasses,
Which is a shame for the myopes.
Exactly that. So you can be unaided 612 and but N5, and if no one's mentioning the N5, then that's the biggest warning sign. If somebody's N5 N4 unaided, that's the patient you really need to spend a lot of time with. And we may see someone who's N5 in a pair of +2.5s, but that's a very different to an unaided N5. So I think it's seeing these patients properly. You want refraction on both eyes. You want unaided visual acuity for distance, intermediate and near, as well as best corrective visual acuity. And I'd also like to try and find what's their historical refractive status. So have they had a recent myopic shift and enjoyed it, or are they fairly static?
Yeah, or even somebody with a cataract with a myopic shift, which gives them the boost for reading, and then you take that away from them. That can be frustrating too as well.
Exactly that.
Yeah, so as an optometrist doing contact lenses, when you do that kind of, multifocal versus monovision, people always talk about what they lose rather than what they gain. They say, but I can't get what I used to be able to have. But we've cleared up your perfect vision for far away. I know, but I used to be able to read so much, and that can be difficult.
And that's I think the greatest cause of dissatisfaction is that, exactly that. So you may give them unaided distance vision and intermediate vision, but you will just really mourn the loss of the near.
So in terms of occupational versus recreational, I know age can be dependent, but what is a kind of, a good question to ask a person?
I don't really have a set of questions. I know some people do, or questionnaires, and there's some iPad tools that have been validated nicely. I tend to just spend some time getting to know patients, and I also send out information in advance so patients know what we're talking about. So if you just spring this on somebody in the chair, they don't understand what you're doing and why, and they might talk about tennis or golf, but they may have only just started and may not continue those habits. It's really risky to set that lens choice based upon a few, what do you do yesterday? How often do you night drive? They might move out to the country and suddenly need night driving much more than before. So this lens is in a patient forevermore, and it's really important to get to know your patient properly. And I think that pre-chair info and letting them think about what they want before they even come in, your patient's already got an idea of what suits them best with some honest literature, and then you can refine that decision.
That's what I was going to say to you. How do you set expectations? So obviously people are coming into you give them all the information, they go for a premium lens, and then maybe they aren't satisfied with the outcome.
Yeah, I think satisfaction is it depends on what you're selling. I hate the phrase, but I'm a big fan of never promising glasses freedom. These adverts we're seeing on TV with bin your glasses, never wear glasses again. Future predictions are a very unwise.
Unfortunately, we still hear that so many times from cataract surgeons. They come back to the high street optometry and they say, my op surgeon told me I don't need glass again. They don't come back for an eye examination because their surgeon said, that's your eyes done now. You don't need any glass anymore. So unfortunately, they don't come back.
I think we, as professionals, need to really clamp down on that. That practice to me is
it's not best practice. It's not professional.
Is a really thin ice to tread on. So I think we need to be really honest about spectacle independence and reduction and trying to minimize. But I think we should all definitely never promise glasses independence, and certainly not try and predict the future. We can't predict the future.
Do you think that's more a generational thing or more kind of a parental thing?
I think it's where surgeons not necessarily write the paperwork, and it's marketing more than medicine. and that's the disconnect. I think surgeons and optometrists and professionals should be involved in writing the literature and writing the websites and the advertising.
Yeah, because unfortunately it tends to lead to miscommunication and then dissatisfaction and then a possible concern or complaint being raised.
Yeah, agreed.
So going back to the fighting cataract and glaucoma with lenses, what's your kind of, choice there?
Yeah, really good question. So we now have some very good MIGS devices, so minimally invasive glaucoma surgery, be that stent or stentless procedures to reduce pressure in patients, eye pressure in patients. Often these patients may already have a controlled eye pressure. So the desire is not to get their pressure down from the mid-20s. It's actually, we're trying to get patients off medication. We underestimate the burden of putting an eye drop in once, twice, 3 times a day, the faff of repeat prescription.
Quality of life.
Quality of life, the side effects that, I've left it behind, I'm off to Spain for the week and I've lost my drops. And the potential ocular surface side effects. So we're frequently seeing cataract surgery as an opportunity. It's a bit of a marketing buzz phrase again, but a reason to consider, don't have to, but consider offering that patient something else in addition to their cataract. Some patients may need or feel like they need a MIGS device and the cataract is an opportunity, and the other way around, some patients are having cataract surgery anyway and we can then add the device on top, but they synergistically and symbiotically merge together quite nicely. So we're regularly doing topical anesthetic only, and then cataract surgery with a MIGS device, and the recovery is almost the same as a cataract surgery.
And in terms of acceptance rate, are people quite receptive to the idea?
Increasingly so, because the safety is safety is paramount, and the safety profile.
But then being drop free afterwards is the bonus.
And again, just being careful not to promise drop freedom. We can give statistical analysis of what the likelihood is to reduce from 2 or 1 drops to drop freedom. But I think, again, just like with lenses, we really should not be promising drop freedom. It should be mentioned as a possibility and what we're aiming for. But it's also just to control this disease, which is glaucoma is a disease for life, just getting adequate control of that.
Talk about visual field defects. Are you seeing a kind of a change in visual field defects in comparison to kind of what was previously there, maybe 5, 10, 15 years ago? I know it depends on when you pick up the condition, but are you seeing more?
I think we're catching glaucoma much earlier than we used to. I think the advent of OCT in the high street and the explosion in OCT devices and ease of access is really helping us diagnose glaucoma early. Arguably, some patients have red disease and not glaucoma.
That's what I was going to say, and green disease too as well. So unfortunately, you have to kind of deal with both.
Yeah.
Do you find you're probably seeing an awful lot more false positive referrals coming into your clinic from the high street?
We are, which can be frustrating, but we also, I've definitely seen a reduction in patients who are presenting late. So, depends on where you are in the country. And David Crabb's done some brilliant work about the postcode lottery of glaucoma detection. Yeah. But I think our late presentation, advanced glaucoma presentations are diminishing, thankfully, which is really, really lovely to see. There's lots more work to do. But I think the combination of eye pressure, visual field and OCT for patients who are at risk or maybe not known to be at risk is just vital. And like you say, that annual eye test, even though there's governmental pressure to make it every 2 years, trying to get patients to come regularly, like the dentist, like a car MOT, that's really useful.
So going back to the premium lenses, we didn't really speak too much about the toric lenses. Could you talk a little bit more about the premium toric lens that are available to you?
Yeah, so all lens categories come in a non-toric or toric variety, and there's a sort of divide there. But actually, I kind of think of them as a continuum. They come in cylindrical steps. Most manufacturers are 0, 0.75, 1.5, 2.25, etc. Some come in 0.5 steps. But we used to just think about doing a toric lens in a patient with, let's say, 1.5 diopters a cyl or more, and that was, corneal barometry, corneal curvature numbers. The latest calculations are using posterior corneal astigmatism and accounting for that either mathematically or directly measured. And the modern lens calculators allow us to basically see whether a toric is suitable for a patient. It gives you an expected spherical and cylindrical outcome for those patients. And some patients with a 0.6, 0.5 diopter of cyl in their cornea actually would benefit from having a toric. They may not want it, they may not fancy that, they may not want to pay extra for that, but it's nice to be able to say this is what you've got, and if you would not like it, this is what we expect to have behind afterwards. The calculators allow us to say that you're going to have a 0.75 uncorrected cyl that you will probably need some spectacles to correct.
Yeah.
So it's nice to have that information before you.
How high do they go up, and is stability an issue?
Yeah, rotation's the biggest one.
Yeah.
And so as a patient lays flat for surgery, the eye can cyclotort up to 30 degrees, and that's that 1 clock hour is enough to take a third off that toric stability. So that, yes, the higher the sill, the harder it is to get it down to a respectable level, but the more useful it would be to put in a toric. So I did a patient last week with 4.5 diopter cylindrical toric lens.
Yeah.
And obviously that's a huge benefit to patients.
And what about any glare or halos at nighttime driving? Is that increased or decreased or similar to just normal spherical?
I think the uncorrected sill is a cause for glare. Glare happens even with a monofocal lens. Patients still get glare, so we are hung up on it. And I think the diffractive trifocals and multifocals really did struggle from that. The EDOF lenses, the monofocal pluses, that glare has been proven to be statistically similar to a monofocal alone. So I think that's where it's switching. I'm not using too many multifocal and trifocal lenses. It's more the sort of monofocal plus, and patients could expect a similar level of glare, dazzle, halos, dysphotopsias, etc., but with that added depth.
Time for a word from our sponsors, Mainline Instrument, leading in ophthalmic innovation since 1997. Mainline Instrument supplies premium ophthalmology equipment from global manufacturers, including iCare, Oculus, Tord Pi, Tomei, Optomed, Huvitz, and Neats. From advanced diagnostics to surgical solutions, explore their products and services or book your in-clinic demonstration at mainline.co.uk. Mainline Instruments. Unmatched service, unbeatable products, unrivaled quality. You speak regularly at national and international events. Do you think the UK are on top of the curve when it comes to lens availability in comparison to competitors in Europe or America? Are we lagging behind?
No, I think we're up there actually.
Okay.
I regularly involved with FDA approval processes, and actually the United States are quite constrained. I think we've got access to a lot of the lens technology. Nearly every lens available is available in the UK, which is exciting to have. The toughest job is deciding which one's right for you as a surgeon and you as a patient.
Yeah, and obviously the patient will take your trust on board too as well. And they say, well, you decide, or you can help me decide, or you're the consultant, you choose.
It's really tough. And then when you add in a financial factor too, there's not just the patient selection and the lens choice and the science behind the lens. It's then it's bang for your buck. What price would you put on that lens? And if one is 2 or 3 fold higher than its competitor, that's a different dynamic. So it's a very challenging area, but also an exciting area.
It's exciting too as well. What can you see coming around the corner, Dan, maybe in 6 months' time or 12 months' time that we don't have at the moment, which will make your job easier?
I think we've mentioned already, posterior corneal astigmatism measurements will become much more commonplace. I think we're seeing the calculations, the biometry measurements becoming much more precise and reliable. It's always confusing to have so many different options available to us, and maybe some formulae that incorporate all of those, or an AI-related decision, which would be quite useful.
I was over in America recently and they have these LAL lenses, light adaptable. Is that something that would have interested you?
It certainly was a vogue for that 10, 15 years ago. I think it's quite restricted to have to wear, ultraviolet blocking glasses, but the idea of fine-tuning that lens later is brilliant.
And it can be done up to 2-3 times too as well.
There's some very good work on simulators, so virtual reality headsets that take an image of a room like we're in today and allowing some VR filters to show what these lenses can do. Because I think what we both know is, although a multifocal, trifocal, depth focus, although they give distance vision and intermediates and increasing levels of near, they do so by robbing Peter to pay Paul somewhat. And actually, it's nice to show patients, actually, yes, you can probably see 6.6, but the quality, the contrast drop. And that's hard to explain. So actually showing that with the headsets.
Amazing. Because not everybody is suitable for monovision, and some people might not be able to get on with it, and vice versa. Some people may not be suitable for multifocal too as well. So it's a fantastic option to be able to have that and, show the patient this is what your vision is going to be like. In terms of computers, do you find computers are making your job a bit more difficult? Because people are on computers now, laptop, physical devices, and, they say half an hour, but it could be 4 hours.
Yes. Well, your phone gives you a regular update about how much you use it, and it's always scarily more than you think it's going to be. But I think, screens have the advantage of being a little bit further away than the average book, especially a desktop. Brighter, and that's the key thing.
They can be internally illuminated too as well.
Exactly. So it's the contrast, it's the backlit, it's the brightness that seems to flatter these lenses more than it does for a book.
And we can increase the font size too as well, which probably we weren't able to do with the kind of the first generation of kind of handheld reading devices too as well. So
So I think patients are expecting to be able to use their iPads and their computers with minimal glasses dependence, and many of them that's what they mean by reading. The hardest one is a sort of paper faded book in a bedside light that's rather dim. That's a very different visual test. The font size can be similar, but the performance of these lenses are very different without the backlit and the high contrast black on white. Faded black on slightly yellow paper is much harder.
Yeah. We're all getting used to AI now, Dan. How important is AI to you in your day-to-day job, and how can you see it changing over the next 1-2 years?
Yeah, I don't know. my chat GPT gets hammered for scientific research as well as my kids finding pictures of cats. AI is coming into our world.
I was talking more clinically. Do you use AI in work?
And yeah, good. Not yet. So augmented decision making, clinical decision support, I think that will be much more a part of our lives. Maybe not necessarily by asking for it. I think OCT software, visual field software, biometry devices will use that decision making to help guide us. I'm hopeful and confident we'll always be able to override it and add your own opinion to it.
Yeah, I think the important thing is it's a tool. It can help you, but it's not going to make you make this final decision.
No, it's just it's giving you some red flags or green flags to that patient will be really useful to highlight those progressing. I think the real benefit for it is out in the community. It's about sort of capturing patients who are at risk and highlighting those to us. I think once the patients are in our chairs, we're pretty good at helping them. It's the unmet
But
need.
sometimes we aren't that good at going out and kind of getting that kind of unmet need, getting into kind of clinic and kind of telling those kind of high risk people, whether it be down to age or race, to kind of come in. How can we approach that?
I think the new DVLA driving assessment is going to really help. So I think
that's taken a long time to happen.
It has, but I think the idea of everyone at 70 having a regular test and a structured test is only helpful. The funding and the frustrations around it are different, but I think we can see some positives in that about capturing patients who are probably at risk and didn't know about it. And genetic testing and polygenic risk scores are going to really help. So we're going to have a bunch of patients who we know genetically are at risk, greater risk. I'm not advocating, government databases about who knows everything about us, but certain patients we're going to say you are at an increased risk and we should target our resources towards you.
We're at the UKEGS conference. Something we'd like to touch on for a second, Dan, too, as well, for maybe people who are in the training program. What is the main advantage, not just necessarily clinically, but the importance of networking within the ophthalmology space? Could you explain to people who maybe don't value that, the importance of it, please?
Yeah, you and I both know the coffee room is where most of this discussion happens. Ideas are bounced off peers. You make friends, you make research links. When you hear eminent speakers on the podium, almost everyone's referencing someone else's work or their research group or their lab or who they worked with 20 years ago. They've collaborated again. Collaboration is key. Research is little tiny building blocks that lead to a greater understanding of a bigger picture. And those building blocks take place in places like this. And that's the same for, resident doctors starting out in their career or very senior clinicians. Everybody helps and builds. And actually, some of the youngest people in this room are taking and sponging some amazing facts from other people, and in a few years' time will be on the podium themselves presenting that work. It all starts a little nugget.
Yeah, and I think that's where we're maybe a little bit scared too as well. We all enjoy being a mentor, being a mentee. We get inspired by people, but making that initial kind of jump to kind of go and say hello, or how do I introduce myself, or how do I get to meet this person, can be very difficult and daunting too as well.
Yeah.
And that's one of the advantages of kind of, these conferences, the ability to kind of say, hi, I really admire your work. I admire your research. Can we have a cup of coffee?
Yeah, one of the best things I've heard recently, I've been to a Cornell meeting, and losartan, so a tablet that's used for blood pressure, it has an eye drop version, and losartan seems to be almost a wonder drug. I hate the phrase, but a very good option for reducing corneal scarring in patients. But it seems to also have a potential role in helping glaucoma surgical outcomes, the same underlying mechanisms. So for trabeculectomy and tube surgery, losartan may be an understudied area that could really change our practice. And actually, just by going to a Cornell conference and taking that away and thinking about it logically, hopefully in a few years' time we have a study that looks at losartan use in glaucoma surgery. And it might not be, but it's those ideas that build our practice.
Talking the controversial topic, GLP-1, RA and optic nerve, problems. So obviously it has been linked with kind of, AION, and also on the flip side, it's been seen as a preservative choice for dry AMD too as well. So it tends to kind of be a Jekyll and Hyde, it's kind of good and bad. What are your thoughts?
Oh, I don't know. Yeah, GLP-1 is everywhere, isn't it? It's what 8% of the population are now taking this drug, whether
it be off-label or on-label. Yeah.
Often off. Whenever you get something that's quickly becoming a popular option, a sort of a boom, and it's talked about everywhere and in newspapers, it's same as a COVID vaccine. The tiny risk and negativity seems to always get blown out of proportion.
In comparison to the benefits.
Yeah, we must remember that obesity is a killer, and it's increasingly common, and it has multifactorial, multi-system issues with our bodies. And being of lower body mass index, it is proven to be hugely beneficial to our health. There will always be a side effect, either just the base rate of NaON in the population, and if there is an increased risk, it needs to be put into context of what the actual risk is anyway without treatment. But it's keeping that into context and not overplaying it. We don't know the answer. It's all case reports so far, but it's an exciting area.
Do you come across it in your line of work much? I mean, it's obviously non-glaucomatous NaON optic neuropathy, but in terms of speaking to somebody who maybe has obesity or is diabetic and is using a GLP-1, is it something you mention?
No, it's a tricky one. So we don't tend to get that information from a GP. Some of it's prescribed. The diabetic patients, it's on a prescription, it's on their medical record. Yeah. But patients who are self-funding that from the local pharmacy, it's not down there. And same as with supplements and other things that we know can be anticoagulants, etc. Supplements and non-prescription items are not always mentioned. If we can ask a patient, which drugs do you take? They'll list off their, anticoagulant, their warfarin, their blood pressure pills, but they may not admit to those.
They don't think of it as a drug. They think of it as a weight loss mechanism.
Exactly. And it's not on the record either. So it's almost having to be a specific question.
Yeah, it's a bit like erectile dysfunction medication, and somebody comes in with the NaION and they're kind of, taking this, but they don't admit it as being a drug. It's just a choice.
It's an awkward question, but I think it's going to be part of our standard. Just like we talk about tamsulosin for cataract surgery, we ask yes or no, because that can be brought over the counter too. I think we're going to be asking directly, are you taking a GLP-1? And what we don't know is what are the effects just during the dosing. And as patients start to come off those, we're not even at that point in time yet, but when patients stop, does the risk disseminate and disappear, or is it a lifelong risk, or is it how does it fade away?
And do you think that will have an impact to obesity and BMI within glaucoma in your treatments?
I don't think this. I think diabetes and diabetic retinopathy, and the big one is cardiovascular disease and orthopedic joint replacements. My orthopedic colleagues think that the rates of joint replacements are going to rapidly diminish as we get lighter as a population. So there's some huge benefits there, not necessarily for sort of cataract, glaucoma.
But in terms of the population getting bigger, in terms of obesity and BMI increasing, will that have an impact on you?
Not necessarily.
So Dan, I believe you have a podcast yourself. Could you explain what it is and tell us all about it?
Yeah, it's not directly mine, but I'm regularly involved in a podcast called the Interventional Glaucoma Podcast. It's more of a mindset and approach for patients with glaucoma and how we manage them. So moving away from trabeculectomy, it's more of a kind of a MIGS podcast, thinking about how we can offer MIGS to patients, where they fit in their treatment paradigm, the treatment ladder, and the way the technology works. It's a comparative discussion about which device is right for each patient.
So this is not for patients, it's more for clinicians?
Yeah, it's professional. So it's optometrists, ophthalmologists, resident doctors. It's a scientific medical podcast. It's on every podcast platform. So Interventional Glaucoma Podcast. It's on Apple, Google, etc.
And is it talked about products or talked about techniques or both?
A bit of both. So some of it is patient selection, some of it's patient factors, some of it's surgical technique, some of it's devices. It's quite broad. It's across that whole MIGS glaucoma space.
Talking about patient awareness and patient information, obviously as a clinician, we talk about the technicalities and the products. Do you signpost any of your patients to any websites which would be a benefit to them, rather than going on Google and finding out all the bad stuff about glaucoma and cataract surgery? What websites do you signpost your patients to?
Can't underestimate the work that Glaucoma UK does for our patients. So we're at UKEGS today, and Glaucoma UK, the charity, put on this roadshow for us every year. They heavily support it and organise it for us. Glaucoma UK is an amazing advocacy program for patients. They have regular patient support groups. They help us support a hotline and lots of patient supporting information. So every single letter I write to the patient at the bottom has a link and a QR code to Glaucoma UK, and that footer can be downloaded. If you ask Glaucoma UK, our colleagues can add that on. But it mentions the DVLA requirements for glaucoma and how you have to report it if you have it in both eyes, affecting your vision. And it gives patients an option to look up some support literature, which I think is really helpful. It's nice to do it in clinic, but we're under so much time pressure.
Have you had any feedback from Glaucoma UK with regard to the uptake of that? I mean, how many people are coming to them via you?
I don't know. I'd love to know. When I first started my training, we had a glaucoma specialist nurse with a little box of eye drops and compliance aids.
Patient information leaflets.
It was full of that. And sadly, that's dissipated and
disappeared. Yeah, disappeared of COVID due to sterilisation and infection.
Yeah, but I think we're pretty good now. Nearly everyone's got a smartphone. Even 18, 90-year-old patients can scan a QR code. Written literature is available too, so they do some good physical leaflets, but often they run out or they're not in the right place. So that letter footer with a QR code that you can scan is just a great idea to signpost patients or their relatives to the right place.
Yeah, and to visually see something to be able to action it too as well, rather than kind of verbally tell somebody.
Yeah. And it's all free. Glaucoma UK is a charity and obviously supported by donations, but all of their literature is completely free to access.
You're a keen runner. So to finish up, talk about your running and where do you go in terms of, you're going to a lot of conferences in Europe and America. Do you always kind of find other people to go for a 5K run with the conferences or 10K runs? You mentioned earlier on about finding a runner. Explain to our readers who might enjoy running too.
See by my smile, I'm a big runner, and just like sustainability is becoming a kind of hot topic at conferences as well as the scientific content, nearly every conference has now got a sort of social exercise sideline. So ESCRS had a 5K run. We haven't got a UK one, but we've hired a tour guide today. So a running tour guide is a thing. Yeah. So everywhere we go, we hire a tour guide who takes us for a 5-10K run around a city, shows us the sights and talks through the historical components of a city. It's a nice club. It's nice. I think most surgeons, doctors live a stressful life and need a release. And obviously you gather us all in the city with free evenings and free mornings before things start. And we tend to kind of, combine our passions and all go out for a run together. So it's, increasingly a thing to do. Last question. Who's the most competitive? In the running, who's the most competitive? My friend Sandro Simplicio in Newcastle. I think he's done 7 marathons this year, and he literally gets off a plane and does another one. He's a machine. Okay. But yes. Yeah. I don't tend to do kind of, city runs. I do a more kind of Spartan run, obstacle course races, and I hate the running element, but I enjoy the adrenaline, I enjoy the participation and the collaboration, and that tends to kind of, get that kind of, endorphins out. I my clearest thinking is when I'm running, put my podcast in, my headphones on and go off into the woods and explore, and all my good ideas come from those minutes. I decompress and then the clarity is just there. It just seems to be my happy space. That's really, really interesting to hear. So you find that the best moments you have are when you're out running? Yeah, it seems to be spent a day, deassemble everything I've heard that day and over the week, and then get some real clarity to rebuild what I've heard and make something happen. So is it more kind of professional that you find the running beneficial, or clinically rather than kind of personally? Everything. It's on every level. I feel fitter, happier, less stressed, and clarity of thought. That's a fantastic recommendation. Thank you much, Dan. Thank you. See you for the next run.